factors and the absence of other etiologies of liver disease. Obviously, when you diagnose somebody with NAFLD, we have to look out for other organ system affection too. These patients might have cardiovascular diseases, chronic kidney diseases, bone-related disorders, obstructive sleep apnea, thyroid issues, PCOS, and also can develop liver and non-liver related cancers. So there is an increased risk for not only death because of liver diseases, but also overall mortality in patients with non-alcoholic fatty liver disease. Now, the most common test that we see in a routine clinical practice is somebody who comes with a report of an ultrasound showing fatty liver. And you must have realized in that report there is certain grading of fatty liver. This is grade 1, grade 2, grade 3, and that indicates mild, moderate, and severe grade of fatty liver. Now, how do the sonologists actually do it? Grade 1 fatty liver is when the liver shows increased echogenicity in comparison to the spleen and the right kidney. Grade 2 is when there is blurring of the intravascular structures inside the liver. And grade 3 is when there is deep attenuation on ultrasound signal and the diaphragm cannot be readily differentiated from the posterior surface of the liver. Now, yes, ultrasound has its own issues, but if you want a more sensitive and a specific test, then MRI, proton density fat fraction, or a CT liver attenuation index, they are more sensitive and specific. But the problem is that they're expensive. It's very difficult to send patients to them because it's expensive. They have limited availability and they're inconvenient to the patients. Now, this is how we diagnose hepatic steatosis, that is an ultrasound, which helps in the grading of fatty liver. We also have non-invasive tools to diagnose hepatic fibrosis. Fibrosis comes after steatosis. There are certain clinical scores that we use which are available online, which includes APRI, FIB-4, NAFLD fibrosis score, and a BART score. APRI includes simple parameters like SGOT and platelet count. FIB-4 includes SGOT, SGPT, and platelet count. BART score includes SGOT, SGPT, BMI, and diabetes, whereas NAFLD fibrosis score is a complicated formula which incorporates age, BMI, diabetes, SGOT, SGPT levels, platelet count, as well as albumin. These formulas are easily available online and you can just put the values and get the results. Now, the common test other than these scores, which are blood parameter based, is a fibroscan, and there is more and more availability of fibroscan in recent times. Now, fibroscan has two probes, the M probe and the XL probe. M probe is for routine patients and XL probe is for obese patients. Now, we have to look at the E value, that is the stiffness. If the E value is more than 8.2, it indicates more than F2 fibrosis. If the E value is more than 9.7, it indicates F3 fibrosis. And if it is more than 13.6, it indicates F4 fibrosis, that is cirrhosis. Now, any E value of more than 20 might suggest clinically significant portal hypertension in the scenario of a low platelet count. Along with an E value, that is the elasticity value, the fibroscan also gives us another value which is called as the CAP. CAP is controlled attenuation parameter and it helps to diagnose steatosis on the fibroscan. So the Indian cutoffs for CAP values in obese and non-obese patients are different, but any CAP value of more than 330 to 350 is considered severe steatosis in the liver. So now we have looked at an ultrasound, we have looked at the non-invasive tests for detecting fibrosis as well as a fibroscan. Now, we all use these tests, all the three of them, to risk stratify the patients and manage the patients with non-alcoholic fatty liver disease. So if you have any patient that comes to your OPD with deranged liver function tests, or an obese patient or a diabetic patient, to screen for fatty liver, we do a routine ultrasound. If that ultrasound shows fatty liver, then we need to be very sure that there is no other related problems because of which the liver enzymes are deranged. Rule out hepatitis B, hepatitis C, and alcohol consumption, and do these non-invasive tests to diagnose whether that patient has fibrosis. That is the APRI score and the FIB-4 score, which is very easy to calculate in OPD basis. Now, if that APRI score or a FIB-4 score it shows a low risk, then these patients are best managed by physicians. These patients should be followed up regularly, and all the associated comorbidities should be treated. But if the FIB-4 score is more than 1, or if the APRI score is more than 0.45, then subject these patients to a fibroscan. If the fibroscan shows a value of less than 8.2, that is less than F2 fibrosis, then it's best to follow these patients regularly and keep on screening with the fibroscan every 6 months to see if they develop further fibrosis. Also treat other comorbidities of these patients, ensure that these patients have do lifestyle modifications and lose weight. If the patient's LSM value is between 8.2 or 13.6, that means the patient has F2, F3 or F4 fibrosis, then comes the role of NASH pharmacotherapy in these patients. Lifestyle interventions and correction of other comorbid illnesses is very essential when we treat the patients for NASH. If the LSM value, as a physician or as a surgeon, we look at the LSM value, and if it is more than 13.6, these patients are best referred to gastroenterologists or hepatologists who have expertise in managing these patients, because these patients tend to have cirrhosis. The liver biopsy is a gold standard to diagnose NAFLD, and we have two scores called as the NAFLD activity score, which includes steatosis, hepatocyte ballooning, and lobular inflammation. And we have got a steatosis activity fibrosis score, which includes steatosis as a steatosis score, and an activity score which includes hepatocyte ballooning as well as lobular inflammation. We'll not go into details of this. We must understand that liver biopsies has their own limitations. There is sampling variability. There is a small but significant risk of complications. We have seen patients die because of liver biopsies. These include pain, bleeding, and even death. It is impractical to repeat a liver biopsy. We cannot convince a patient to do two-time biopsies to see if there is an effect of the medicines. There is limited expertise to read the liver histology. There is intra-observer and inter-observer variability, and we cannot do a liver biopsy in an OPD basis. We have to refer them to a place which has got a good backup. But in those clinical situations where the non-invasive assessment is inconclusive or falls in the gray zone, or when the patient has other confounding etiologies, a liver biopsy is a must to definitively diagnose NAFLD or NASH. Moving on to the treatment of NAFLD. The treatment encompasses control of the risk factors, intervention in the lifestyle, weight reduction, which is the key, which is done with lifestyle modifications, certain drugs, with bariatric surgery as well as endoscopic bariatric and metabolic therapy. Then there are medications for comorbidities with the patient of NAFLD, medications for NASH per se, and liver transplantation in those who have decompensated chronic liver disease because of NAFLD, or those who develop HCC within transplantable criteria. Weight loss is the key. You have to concentrate on this particular aspect for the patients who come to the OPD. There is a dose-dependent relationship between the magnitude of weight loss and the degree of histologic improvement. A weight loss of 3 to 5% improves steatosis. Weight loss of more than 7% improves steatohepatitis, that is even inflammation. And a weight loss of more than 10% improves even fibrosis. So in those patients who are overweight or obese, tell them to restrict their calorie intake by more than 30%, or around 500 to 1000 kilocalories, by cutting down on carbohydrates and fats in their regular staple diet. In patients who are lean, the energy intake should be equal to the expenditure. The total fat that we consume should be less than 30% of our total energy intake. The trans fat should be as less as less than 1%. Avoid free sugars. Shakkar khana mana hai. Free sugar should be less than 10% of the total energy intake, ideally less than 5%. Avoid fructose and sweetened beverages. More than 2 cups of coffee is good, but ensure that the coffee does not have full cream milk, full cream or sugar. That is a strict no. Calorie restriction is thus the key. And some say that Mediterranean diet really helps, but I personally feel is that the local staple diet is better because it has more adherence. So we should avoid ultra-processed foods, saturated fats, processed meats, sweets, high-fat sugar dairy products, alcoholic beverages, as well as your routine Coca-Cola or aerated drinks. Now let us have one small slide about Mediterranean diet. Everybody asks about what is Mediterranean diet. So every meal should have 1 to 2 servings of fruits and vegetables. Daily there should be 2 servings of low-fat dairy products or olives, nuts and seeds. And weekly once or twice we can have white meat or fish. This includes the Mediterranean diet. Exercise is the key. Moderate intensity aerobic as well as resistance exercise for at least 30 to 45 minutes a day for at least 5 days in a week, irrespective of the body weight, is very essential. Tell patients to take Saturday, Sunday off, but rest of the days they should exercise. And exercise includes as simple things as brisk walking, jogging, running, swimming and cycling. For patients who have arthritis, joint issues, if they are very obese or if they have a poor cardiorespiratory reserve, resistance exercises can supplement aerobic exercises. And the role of yoga actually is really unexplored and probably has a role in reducing reducing fat in the patients with non-alcoholic fatty liver disease. There are certain weight loss drugs available, but none of them are recommended. We have spoken about bariatric surgery, we have spoken about endoscopic bariatric and metabolic therapy. I'll not go into details of this, but basically bariatric surgery is a restrictive and malabsorptive and included biliopancreatic diversion with a duodenal switch, Roux-en-Y gastric bypass, sleeve gastrectomy and an adjustable gastric band. And we have also got endoscopic therapies. I think Dr. Nitin would be the best person to discuss about this. Then comes the pharmacological management of other comorbidities associated with NAFLD. Now these patients tend to have diabetes. We have seen almost 50% of diabetes have NAFLD, and metformin is a good drug in these patients. It improves liver biochemistry but does not improve liver histology. GLP-1 analogs like liraglutide and semaglutide have beneficial effects. Pioglitazone is a good drug but causes weight gain. SGLT2 inhibitors like empagliflozin are promising, and there has been a study done by Medanta in India about the beneficial effect of this drug. Addition of GLP-1 analogs with SGLT2 inhibitors is best because they cause weight reduction and that has beneficial effects on NAFLD. And if the patients are dyslipidemic, please give them statins. Don't worry about the liver enzymes because statins are protective. We look at 3 specific drugs that we routinely use in the practice when we treat NAFLD, which is vitamin E, pioglitazone, and saroglitazar. Now this has been a landmark trial which has put the position of vitamin E and pioglitazone in the armamentarium for management of NAFLD. So this was the PIVENS trial, which looked at 247 patients with biopsy confirmed NASH who did not have diabetes, who did not have viral hepatitis or heart failure or cirrhosis, and these patients were randomized to receive pioglitazone 30 mg daily, vitamin E 800 international units daily, or a placebo for 96 weeks. The best part about this study is that a liver biopsy was performed before the start of drugs, and the liver biopsy was performed at the end of the therapy of 96 weeks. And again, another best part of the study was that the patients were followed up for at least 120 weeks after the stop of therapy. Now what did the PIVENS trial show? It showed that vitamin E significantly improved histologic features in NASH. Pioglitazone also improved features, but that was not significant. Vitamin E as well as pioglitazone significantly reduced SGOT and SGPT levels. Neither agent improved fibrosis. They improved histology, but they did not improve fibrosis. Though pioglitazone improved insulin resistance, it was associated with a lot of weight gain. So the trial concluded that in patients with biopsy-proven NASH without diabetes or cirrhosis, vitamin E is a potential treatment option and is superior to placebo. Pioglitazone may also have efficacy, but the problem is weight gain. So INASIL recommends the use of these 2 drugs in the treatment of NASH and NAFLD. The suggested minimum duration is at least 2 years. So if you're starting the drug, give it for at least 2 years. The next drug is the PPAR, that is the peroxisomal proliferator activated receptor alpha and gamma dual PPAR agonist, which is saroglitazar. PPAR alpha improves plasma lipid profile, it increases fatty acid uptake, improves fatty acid oxidation, improves HDL, reduces VLDL and triglycerides, and is anti-inflammatory. Whereas PPAR gamma improves insulin sensitivity. It increases the beta cell function, it increases adiponectin secretion, increases fatty acid uptake, and is also anti-inflammatory. So we have saroglitazar, which is a dual PPAR alpha and gamma agonist, and the Director General of India for the drugs has approved the use of saroglitazar in NASH patients with F1 to F3 fibrosis 3 years back. Now this was based upon the Evidences trial, which was a phase 2 study, and the dose is 4 milligrams per day. What the trial showed is that those patients who received saroglitazar had a reduction in the SGPT levels, had improved insulin resistance, reduction in the triglyceride levels, reduction in NAS score, but there was no significant weight gain. Please see that the minimum duration of this drug has to be at least 1 year. The drug also improves steatosis, which was evaluated using the MRI PDFF. It does improve liver functions in across the parameters including SGOT, SGPT, alkaline phosphatase as well as GGTP. Another trial which was published this particular year looked at saroglitazar and how it improves fibrosis in 63 patients, amongst whom 50% were diabetic and 11 had compensated cirrhosis. Saroglitazar improved fibrosis, improved the CAP values, reduced the SGOT, SGPT levels, reduced HbA1c, LDL, total cholesterol as well as triglyceride levels. But the problem in that, in one patient there was pleuritis and one patient had GI upset, but that is very minuscule. So saroglitazar is a good drug to use in those patients who have diabetes along with hypertriglyceridemia, diabetes and patients with NASH. So in this particular set of patients, saroglitazar works really well. So what are the factors when you consider before starting drugs? Vitamin E, it is widely available, cost-wise effective, it is recommended by international societies in biopsy-proven NASH without diabetes. We are not sure whether it really works on fibrosis. The problems with vitamin E is that long-term use can potentially increase the risk of CA prostate or hemorrhagic stroke, but there is no increased risk of all-cause mortality. Pioglitazone is also recommended by international societies in biopsy-proven NASH. It can be used in patients even with diabetes. We are really not sure whether it works on fibrosis, and the problem with the drug is that it causes weight gain and probably osteoporosis in females. Saroglitazar, the only approval was a phase 2 study. We really do not know whether it works on fibrosis. The problem is the cost, and it is only available in India. We have many other drugs in the future that are going to be a real game changer in the treatment of NAFLD. I will not go into the details of them. So drugs act at various levels inside the liver, including beta oxygenation, lipogenesis, inflammation, apoptosis, fibrosis, and steatosis, as well as outside the liver in terms of insulin resistance, acting at gut dysbiosis, acting at the fat cells, acting at the muscles, as well as the kidney level. I'll talk only about two specific drugs which are potentially going to be the game changer in the coming few years. First is the FXR agonist obeticholic acid, and the second is the GLP-1 agonist liraglutide and semaglutide. Now, FXR agonist obeticholic acid was given in the dose of 25 milligrams in those patients who had biopsy-proven NASH with a fibrosis of more than 2 or 3 and a NAFLD activity score of more than 4. And look at what the drug did. It reduced fibrosis. This was the only drug that showed reduction in fibrosis, not just histology, but also reduction in fibrosis, at least by one stage in 38% of patients, and in more than 2 stages in 13.3% of patients. But problem with the drug was the adverse events seen in more than 90% of the patients. If you can look at bottom on the right side, the problem with pleuritis with that high dose was almost in 50% of patients, causing a lot of dropouts. Also, these drugs increases the LDL level and causes gallstones. So at present, not recommended. Then we have GLP-1 analogs with multifactorial effects on NAFLD, on obesity, on kidney disease, cardiovascular disease and diabetes. And the first GLP-1 agonist was liraglutide, which was seen in the LEAN trial, which showed a reduction in weight as well as the SGPT levels, and it improved even histology. The second drug, which is the hot topic now in NAFLD, is semaglutide. It was studied in a multinational double-blind, active control, placebo, phase 2 dose-ranging RCT, and the aim was to evaluate the effect of semaglutide in the subcutaneous form on SGPT levels in patients with obesity without diabetes in a phase 2 trial. And the dose that was recommended was 0.4 milligrams of semaglutide subcut daily. Now it showed that, look at the amount of weight loss. Taking this particular drug causes good amount of weight loss in the tune of almost 13.8% when we give a dose of 0.4 milligrams. It also reduces the SGPT levels as well as causes normalization of the SGPT levels at week 52 in almost 50% of patients. So we looked at these particular two drugs which are going to be the future probably of NAFLD therapy. Now what about patients who have cirrhosis of liver along with NAFLD? Which drugs do we give in these patients? Vitamin E and metformin probably is found to lower the risk of hepatocellular carcinoma, need for transplants, hepatic decompensation and death, but these are all been retrospective studies and single center data. So we really do not have any particular drug that can be used in patients with NAFLD cirrhosis per se to treat the NASH component. Moving on to the last 4 slides. Individual topics in itself, but I'll just give you a brief about them. NAFLD in children and adolescents is a big problem nowadays. The pooled NAFLD prevalence is around 12.4% in non-obese Indian children and around 63% in obese Indian children. Most children are asymptomatic and are diagnosed incidentally. If at all you find a small child who is obese at a very young age, be sure to rule out genetic causes that are defects of fatty acid or carnitine metabolism, paroxysmal disorders, LSDs, or Wolfman's disease. The best tool to screen these patients is ultrasound, but please note that an ultrasound has a low sensitivity for milder degrees of steatosis. So the best actual test is an SGPT level for children more than 9 years or overweight children who have a family history of NAFLD or other risk factors. If the SGPT level is very high, try and search for other etiologies. It may not be NAFLD. Liver biopsy is mainly restricted to those children in whom there is a diagnostic confusion, and there is a difference between liver histology of adults and children. In children, there is more of zone 1 centered steatosis, inflammation, fibrosis. In adults, it is zone 3. In children, there is less ballooning. In adults, there is more ballooning. Lifestyle modifications is the mainstay of management. We really do not know whether vitamin E helps in children when given for a long period of time. Then comes lean NAFLD. Now, lean patients with NAFLD have a milder liver histology as compared to obese patients. The problem is visceral obesity. They also might have genetic predisposition and unhealthy dietary pattern, which may be associated with the lean NAFLD. The long-term outcomes of lean NAFLD patients are better than obese NAFLD patients, but they have a higher all-cause mortality or cardiovascular mortality because of the visceral adipose tissue and insulin resistance. We manage them on the same lines: lifestyle, sleep interventions, pharmacotherapy, and management of other comorbidities. Coming to the last part, liver transplantation in decompensated chronic liver disease because of NAFLD. Few takeaway points. Obesity in decompensated NASH, the best treatment is to tell them lose weight. No bariatric surgeries, please, in patients with CTP class more than A, B, or C. Cardiovascular risk has to be thoroughly assessed. These patients might have a cardiovascular abnormality or a coronary artery disease, and they may not be even fit for a transplant surgery. Also look at renal dysfunctions. Diabetic patients have CKDs and they may require a combined liver kidney transplant. Corticosteroids are best tapered early after liver transplants, depending on the center experience. All the immunosuppressants that we use after liver transplant, everolimus, sirolimus, tacrolimus, all of them worsen the metabolic profile. So the best drug is MMF, but best left to the transplant hepatologist. And post-liver transplant, recurrent or de novo NASH should be managed, is also a known entity and should be managed with lifestyle interventions without any specific drugs till further data is available. We have used saroglitazar in these group of patients, and these patients have done well, but there is more data that needs to be found out. So the key takeaway message is, NAFLD is an emerging healthcare epidemic. It is a spectrum that extends right from steatosis to steatohepatitis to fibrosis to decompensated chronic liver disease as well as hepatocellular carcinoma. If you see a patient with NAFLD, don't just look at the liver, look at the heart as well as the kidneys, look at diabetes also in them. There are various non-invasive tests that are available to diagnose NAFLD fibrosis. We have scores that are easily available online as well as a fibroscan at our disposal. Liver biopsy, though a gold standard, is rarely performed unless only in specific indications. NAFLD is a lifestyle ailment. Tell your patients, motivate them to have good diet and exercise because that forms the cornerstone of management. Currently, 3 drugs: vitamin E, pioglitazone, saroglitazar. Future, probably obeticholic acid, liraglutide, semaglutide. And NAFLD DCLD could be one of the most common indication in the future for liver transplantation. I really thank you for your patient listening. International NASH Day is celebrated on June 8th this year, and you may educate your patients about NASH on this particular day. And we're already through lunch. Thank you.
Thank you, Dr. Sonone. You have made a very complex topic so simplified. My compliments to you. I think any of my co-chairpersons would like to add something on it.
Very nice and lucid slides were there, and a nice topic. Just I want to ask you, will you give some advice to here all physicians and general practitioners, because a lot of patients are directly coming to them only, and being attached to medical institute, I think this topic is very neglected topic, and this is not emergent topic. So just write a short note on NAFLD or NASH. So what are the practical aspects? Means like how practically we should go ahead with this topic?
So if you have any patient coming to with an ultrasound report, look at the LFT. If the LFT is abnormal, rule out alcohol, rule out hepatitis B and C. Obviously the profile of the patient, obese patient, diabetic patient, probably would have NASH. Tell them to undergo fibroscan. If the fibroscan is normal, best kept to all. If the fibroscan shows some degree of fibrosis, then we have saroglitazar, especially in those who are diabetics and having hypertriglyceridemia. We have also vitamin E and pioglitazone. There is a good drug, Evitol, which is vitamin E as well as omega-3 fatty acid combination. And if these patients have got cirrhosis, best sent to a gastroenterologist for further management. I think that would be the nutshell. And we have a gastroenterology colleague here. How is your experience with saroglitazar?
I think it's very excellent drug because most of the time, initially I advise with the lifestyle modification, and then when there is a high CAP score when it falls into the S2 or S3, or the fibrosis level is more than F2, generally I prescribed it. I have seen more than 80% of my patients, they have degraded to the F1 or F2.
Same, I think it's the same experience. Lifestyle modification, saroglitazar really helps.
Only issue with the saroglitazar because its cost
and
is
duration,
very high.
1 year.
Yeah. I think it costs around 2,000 per month and all. That's the issue. But if the patient is affording, then directly we can go for it.
But there is no shortcome to hard work.
Yes.
Diet and exercise. And we all had a fatty liver diet just some time back. All right. Thank you for your patient listening. Thank you.
Before I conclude, myself and on behalf of my co-chairpersons, I would like to thank the organizers, IMA Pune and Dr. Dadasaheb Maindad, for inviting us for chairing this session, and I am pleasantly surprised to see a full house on a Sunday. I compliment the organizers. Thank you.
Thank you, sir. Thank you, Dr. Sonone. It was an excellent talk. Please come over here. I request our President, Dr. Raju Variani, sir, Dr. Shubhada Joshi, Madam, Secretary of GPA, to come on the dais to felicitate Dr. Sonone, sir. And I request Dr. Rajan Sancheti, our President-elect, to be on the dais, please. Madam, yes, sir. I request Dr. Variani, sir, to felicitate the chairpersons, Dr. Bhosle, sir. Dr. Rasai, sir. Dr. Kocharis.
फोटो साइड होगा तो
एक फोटो शुभदा Let's now go to the next talk. May I invite the next speaker, Dr. Sujay Kulkarni, and to chair the session, chair the session, may I request Dr. Sandeep Kulkarni, Dr. Harshavardhan Dongre sir, Dr. Manish Kolke, Dr. Sachin Yadav sir. Dr. Sandeep Kulkarni is a gastroenterologist in Sahyadri Hospital, Pune. Dr. Sachin Yadav sir is physician, Chintamani Hospital, Pune. Dr. Manish Kolke is the physician at Rao Hospital, and Dr. Harshavardhan Dongre is the assistant professor of gastroenterology at Bharati.
So good afternoon. I know this is a Sunday afternoon and I'm giving lecture in a postprandial session. So I try to be as brief as possible because I'm going to open a Pandora's box. So small bowel would have been, previously to be considered as a Pandora's box because very difficult to evaluate. The endoscope cannot reach beyond ligament of Treitz. Colonoscope cannot go beyond terminal ileum, and what we are left with and laparotomy and everything. So, but now things are changing, and as we have now many non-invasive investigations and scopies with the help of which this Pandora's box can be opened. This is no longer a Pandora's box now. So, coming to the scope of this lecture. This is what American College of Gastroenterology says, that what armamentarium do we have to evaluate small bowel. So this is what all we have, and I'm going to speak and stick about capsule, the radiological methods, that is CT enterography and enteroclysis, and most importantly the enteroscopy. So generally this is the first and foremost question to come into any general practitioner, physician or surgeon or gastroenterologist, that why we should evaluate. So these are the indications. Patient will come to you with these common causes for which the small bowel evaluation might be necessary. So first thing is suspected small bowel GI bleed. Then the patient may present with subacute obstruction to surgeon. The patient may also have a pain in abdomen of small bowel origin, which is typically periumbilical, spasmodic, on and off, aggravated by food, relieved by passing flatus or stool. And of course, history of weight loss, malabsorption. So these are the indications where you should look for a small bowel disease. How you should have, I think there is nothing more important than taking good history and having a good clinical examination. So good clinical history, physical examination is important. Medications, especially few point I want to stress upon is medications, especially NSAIDs, whether patient has received any radiation, coagulation disorders, trauma, prior surgery, and prior endoscopic intervention. So these are the things which will affect your patient's diagnosis. A few things which we should look for on general examinations, like what the picture shows, typical telangiectasia. If these are visible, this is what you can see on colonoscopy or endoscopy. So you can have telangiectasia inside also. So this is a typical spider, what we see on the skin, and similarly we can say that there is a portal hypertension, you may get varices inside. So these are small pigmentation in the buccal mucosa, which can predict small polyps inside the abdomen. Usually these patients present with abdominal pain, GI bleed, anemia. So these are the small things. So once we have our general clinical examination, history and all those things, what challenges do we face? So first and most important thing is the small bowel, the length. It is the length which limits our evaluation. So as a common sense, if an endoscope or any scope per se to pass through GI tract, the tract must be fixed. Then and then you can pass it fixed easily. But here, small bowel is intraperitoneal. Your esophagus is retroperitoneal, stomach is mobile, but duodenum is retroperitoneal, so you can easily traverse through, the endoscope easily traverse through that area. But small bowel is intraperitoneal organ. It is covered almost by entirely into the peritoneum, so it is freely mobile. So in a mobile structure, you cannot push your scope and just go on. That is not possible. So what you have to do is you have to pull the intestine onto the scope. Then and then only your scope will move ahead. So that is how things should be done. So now we have capsule endoscopy, enteroscopy, and CT enterography, through which these challenges can be met very easily. And as things progress, as more and more research will go on, more and more techniques will be available. So just, I don't want to go into details of the American College of Gastroenterology guidelines, but this slide I have just put forward. Why? Because why I am stressing on CT enterography, capsule endoscopy and deep endoscopy. So in an evaluation of small intestinal GI bleed, you can see these three play an important role in evaluating the small bowel. So that's why we will discuss these three in our next few slides. So enterography is itself, as name indicates, it's a imaging of small bowel. So small bowel imaging mainly done by a CT. So CT enterography is when a patient is subjected to, he is asked to take a lot of contrast, which usually is non-dense contrast, which he drinks for a period of for quite a lot of time, at least 2 to 3 hours will take that, so that the contrast reaches deeper into the small bowel, and then IV contrast is given and CT is being taken. So this is CT enterography, what we say. See, in our day-to-day routine, we do more CT enterography than MR enterography, but MR enterography performs well when we have to differentiate between and stricture activity of inflammation, whether it is inflammatory or it is fibrotic. What is enteroclysis? Entero is intestine and clysis is washing out. So you have to prepare patient well before doing this procedure. You have to give a complete thorough bowel wash by like what we give for colonoscopy, and then a nasojejunal tube is put. What happens is when patient drinks contrast, the majority of the contrast is consumed by the stomach, and very few, small quantity of contrast reaches upper small intestine. What we want is, unless the whole intestinal tube is distended to the maximum extent, we cannot make out a subtle structure inside it. So to make out a subtle structure, subtle abnormality, we have to distend the intestinal tube to its maximum limit, and so that maximum amount of this given contrast should reach the deepest part of the intestine. That is only possible if you bypass stomach. And to bypass stomach, what we do is we put a nasojejunal tube, either endoscopically or a fluoroscopically. The other end of the tube, one end lies outside, the other end of the tube lies well beyond ligament of Treitz. So whatever contrast is being injected will go straightway into small bowel and will not stay in stomach. So this is what is importance of doing all these things. So that is how the small bowel is distended to its maximum, and then IV contrast is given, and then CT is done. So this is how a CT enteroclysis is done, and especially this is very good for Crohn's disease. So what type of contrast we use? Either we use a neutral versus positive contrast. So preferably neutral contrasts are used because they allow good enhancement of walls and structures, while positive contrast will give more information about the lumen. So here you can see the comparison. They have neutral contrast have attenuation similar to that of water, for example methyl cellulose, and intravenous contrast is used for neutral agents. So these agents allow better mucosal enhancement and mural thicknesses and mesenteric vasculature. One advantage of this CT is it also shows what is going on in and around the intestine. So typical comb signs, vasculature, inflammation in and around, fistulas, those things are lymph nodes are easily assessed by these things, because endoscopy per se will not give idea regarding these things. So this is a typical picture where you can see thickening of the small bowel nicely visualized on CT enteroclysis. On left side it is a methyl cellulose, while on right side barium is given. So there are multiple types of enteroclysis: single contrast, air contrast enteroclysis, and methyl cellulose enteroclysis. What we use in our day-to-day practice is methyl cellulose enteroclysis. So this is how barium looks like. So you can make out from last picture that barium will not give you idea regarding the wall thickness, any structure. It will show you the lumen. So what we want is, we don't want only lumen, we want the wall structure and thickness also. What information do we get from enteroclysis? We get whether there is inflammation or not, whether there is stricture formation or not, whether there is a penetrating disease like Crohn's disease, so fistula, sinuses, abscesses, as I told, and perianal disease and any other information regarding apart from the bowel and lumen. So this is a CT enteroclysis where the arrow shows the thickened ileocecal junction, and this is CT enteroclysis showing suggestive of ileocecal cox. This is again another CT enteroclysis where you can clearly delineate a thickened bowel loop, and that is having a long segment thickening, most probably a Crohn's, and typically multifocal also, so likely Crohn's. So this is again another CT enteroclysis where you can easily make out a thickened bowel loop. Another good thing is it gives you mapping. Intestine is very long. From where to go? Previously we used to have single balloon enteroscope where we have to decide whether we have to go from above or whether we have to go from below, either antegrade or retrograde approach. Where we should approach, that is decided by CT enteroclysis. So it also gives us mapping whether the lesion lies in proximal jejunum, distal jejunum, proximal ileum, distal ileum, and how we should approach. So that is also very important. So when this with this knowledge, I think we should move forward. Once a patient is coming to you with obscure overt GI bleed, you have CT enterography done. CT enterography doesn't show any obstruction. So then you move on to next investigation, that is video capsule endoscopy. So video capsule endoscopy was started in India in early 2000s, and as we come to know, it's a small capsule, say around 25 mm, and what it shows is it has a receiver, transducer, and what you can see there are multiple parts. It has a vision module, battery, communication module, sensor module, and CPU module. So these are the things, and this is how it is attached to the body of the outside structure is attached to the body of the patient. You can see the capsule is swallowed and it contains a battery which works for say 7 to 8 hours, and it takes multiple photos, say around 40 to 50,000 photos, and then it moves on, and the same photos are captured outside by the transducer and recorded, and these photos are subsequently analyzed and the reporting is being made. So these are the available capsules what we have. They have some differences in the angle they visualize, and more or less they usually pass out through after 18 to 20 hours, and then we can analyze photos whatever they have taken. So of course, a person who cannot swallow, a person who is likely to have stenosis strictures should not be given capsule, because capsule may get stuck over there. So these are the different studies for capsules. I don't want to go into details. Limitations are the position of the capsule cannot be controlled. You cannot say capsule to look on left, look on right. So you don't have any control. It is there are certain views which capsule cannot see. So capsule cannot see behind the fold. Any lesion which is obscured by fold will not be visualized well on capsule. Interpretation of results is very observer dependent. So to what we do in our day-to-day routine endoscopy practices, we take biopsy to reduce the observer dependent bias. But here that option is not there. You cannot take tissue. The inability to biopsy make this observer dependent bias even more, and finding may not be of unknown significance and relevance. It is very possible. You cannot move back capsule again backwards to have a second look on that image lesion. Once the capsule passes from that area, it will go away. Main use of capsule where enteroscopy cannot be done is in small children. So capsule has been proven very safe in infants and children because of their mere small size. Enteroscope cannot be passed deep into their intestine, and their capsule may prove the capsule may be the only savior in diagnosing diseases. So what complications it may have, though very rare, the capsule may get stuck, the chemical and sometimes peritonitis may occur, but these are very rare complications. We have encountered a lot of times that capsule has been swallowed, and because of the stricture, it got stuck inside, and because of that, either surgery or enteroscopic intervention was required to remove that capsule. But now with this patency capsule, which goes inside and disintegrates on its own, can be used even in stricturous conditions where capsule gets disintegrated inside and no need to do a big intervention. So these are few pictures of capsule. These are telangiectasia. Especially capsule study is indicated in patient with obscure overt GI bleed. So these are patients who were presenting with anemia, and when capsule was done, these kind of telangiectatic lesions were found. So this is again a patient who has presented with malabsorption. You can see the blunting of villi on capsule endoscopy. This is the patient where capsule got stuck, and we can see it is a stricture because of the Crohn's disease, and capsule got stuck because of this. Capsule stayed there, and the last photo was only this, and subsequently surgery was required to remove the capsule. Now we have seen CT enterography, we have seen capsule, we know where the disease is, we have mapping, but we have to act, we have to do something. To act, we have to reach that area. You just cannot do capsule and CT enterography and act. To act, you have to reach that area. One way of reaching that area is opening the abdomen. The second way of doing it is by enteroscopy. So what questions remain unanswered even after capsule and CT enterography are the tissue diagnosis and therapeutic interventions, which is not possible even after capsule. So then that's why the enteroscopy was invented. And what qualities do endoscopists require? I think you have to have patience, you have to have persistence, and you have to stand like a wall, because the patient comes to you after endoscopy and colonoscopy. By the time patient presents to endoscopist, it is already seen by physician, gastroenterologist, surgeons, and so many more. So you are a third or fourth person who is seeing in. So you are the wall of the department, and the patience and persistence is required, because enteroscopy never happens in one go. It takes 2 hours, 2.5 hours, 3 hours, and interventions take even longer. So, I mean, briefly going through the history of endoscopy, it started everything in 1970 when push enteroscopy started. And then the breakthrough came when the balloon got introduced in early 2000s, and this is the time where enteroscopy started in India. Lot of procedures were done on single balloon enteroscopy, and things really started change after this lockdown. So say maybe 2020 or so, when power spiral got introduced. So there is something called as device. As I told you, you cannot just push the scope and see the intestine. You have to have something which can pull the intestine over the scope. So that something is device. So whatever device we use, depending on that, the enteroscope is classified. So either it is balloon assisted enteroscopy or it is a spiral enteroscopy. Balloon assisted enteroscopy may be single balloon, maybe double balloon. So how balloon helps? So this is how this animation will show you how balloon helps. So scope is passed through an over tube. The end of the tube is occupied by a balloon which can inflate and get attached to the intestine, and you can shorten the loop and make the intestine straight, and further scope can be passed. So you can see how the intestine is being pulled over onto the scope, and the scope is advanced further. This is a 66-year-old patient from Pune who presented with recurrent abdominal pain and weight loss of 8 kg in 4 to 5 months. Colonoscopy was done in Pune, which was normal. CT enteroclasis was done further, then which showed a distal ileal lesion, distal ileal thickening, short segment. We did his endoscopy in mirrors. We went 150 centimeter beyond ileocecal valve, and this is what we got. So you can see this. There is a large mass with a nodular growth and friable growth, which from biopsy from which was showing lymphoma. He took chemotherapy and he is completely all right without doing any surgery. So how an ideal enteroscopy should be? There should be ability to explore almost entire intestine. You can move to and fro. If you want to analyze anything, you should be able to readjust the scope. You should be able to steer the scope, and should have almost all therapeutic capabilities like that of routine endoscopy and colonoscopy. And it should be relatively non-invasive. It should have less time consuming. So what if we can combine speed, power, and will have less efforts? Then I think probably what we will get this. So what power spiral does is, the device where we just saw how balloon is used to pull the enteroscope over the scope, pull the intestine over the scope. Here the the spiral over tube rotates and pleats intestine over the scope, and the whole whatever exhaustive time spent in doing the same cycles again and again will be saved, and the scopy becomes more easy. So this is how you can see it's a 118 centimeter long. So the endoscope what we saw previously was single balloon was having a longer length. So every accessories for every therapeutic has to be lengthened. So long accessories are required. The channel is small. Here the length is that same as that of colonoscope. So everything whatever you can pass through colonoscope will be able to pass through this also. The diameter of the channel is long. It's a 3.2 mm diameter, and this is how the overtube looks like. It has serrations which are made up of plastics, which are non-traumatic, just enough to catch hold of intestine and rotate it along. So this is how the assembly is being made, and this is just a brief animation how how a power spiral works. So this is the overtube which rotates over the distal end of the scope, and this is how the scope is being passed. And as you can see, the tube gets rotated and pleats intestine over it, and scope moves forward. So those exhaustive steps of which we do in case of balloon, which are not needed, and most importantly the time is saved. Within 30 to 45 minutes you can see almost entire intestine, and at least 40 to 50% of the times you are able to reach cecum from above, which is very important. So you can, the depth of intestine which you have examined, it's increased to maximum. This is how it looks like when you do it. So advantages: deeper insertion, as I told, reduction in procedural time, ease of use. You don't have to, it's not exhaustive. The cycle which we make are for balloon endoscopy are exhaustive. It's very easy to do therapeutic procedures. As I told you, the channel diameter is more and the length is shorter. So this is the comparison of spiral versus balloon, and the same thing what I told you are here. In less time you can do more and more. So that is what the power spiral tells us about. So this is a foreign study where 264 patients were included, and as you can see, the depth of insertion is literally 450 centimeters. So you can go that much beyond ligament of threads, and you can also see the procedure timing is reduced to less than an hour. So for single balloon, it used to be 2 hours, 2.5 hours, 3 hours, but here it is less than an hour. So that is how you can do better by doing having a power spiral endoscope. So diagnostic yield also increases as you can examine more area. You can reach deeper parts of intestine. Obviously, the diagnostic yield will increase, and if you have good therapeutic channel, the shorter the length, more accessories you will be able to pass, and you will also therapeutic yield will also increase. So this is, we have seen just the foreign publication. So this is a publication from my own alma mater, AIG, where they have shown that it's around 92 patients, and the similar results were shown by them. One thing I want to highlight here is the length they reached. Almost 50 to 60% of the times they reach cecum from above, so which is not a small number. So if you can examine pan and enteroscopy, what we call it as, in one go, nothing like that, and almost 60%. And a slide will come in next slide. I will show that possibly if you combine antegrade and retrograde approach with power spiral, it is possible to see almost 80% of the times you can see the entire intestine. So in this slide, you can see if you combine antegrade and both approaches, almost 85 to 90% of the times you can see the entire intestine. So this is not a small number. So balloon versus spiral, both are safe, effective techniques. You can save time by motorized power spiral. It has higher diagnostic yield. You can reach better. I mean, you can examine more length. You can reach deeper, and future randomized trials are still warranted to compare. But this is what we have as of today. So there are some contraindications. Obviously, in a perforation and where the esophageal or dysphagia is there, you cannot utilize it. The pore spiral over tube has a larger diameter, so you may require dilatation before doing procedure if the patient is frail and thin. So sometimes now, apart from what we have seen, what are other implications where enteroscopy is being done? So this is retrograde enteroscopy. I have told you 60% of the times they reach cecum from above. Now AIG has started doing enteroscopy from below and started reaching duodenum. So this is, near complete enteroscopy from retrograde enteroscopy, from retrograde aspect. So this is also they have done. So next application is enteroscopy assisted ERCP, from in whom those who have altered anatomy, Uru-NY anastomosis or gastrojejunostomy, in those cases, enteroscopy will assist you to reach the area of hepaticojejunostomy site or the papilla, and you can do ERCP in an altered, surgically altered anatomy. So this is the publication where it states that previously when power spiral got introduced, it was suspected that in a surgically altered or prior history of surgery, because of adhesions, power spiral will not do well. But this is the publication which tells us that even in prior surgically prior operated patients also, the power spiral does well and can go very deep. So this is a publication which says that previously incomplete colonoscopies also can be completed by using the power spiral. So these are different uses of power spiral other than a typical antegrade enteroscopy. So motorized power spiral appears to be effective and safe. Total, that is pan enteroscopy, can be achieved in 1 or 2 sessions, even in presence of surgically altered GI anatomy. The total procedure time is relatively shorter. For both antegrade and retrograde motorized power spiral procedures, propofol sedation seems to be efficient and safe. So this is a power spiral enteroscopy, what we have done at our center. You can see, so in this video you can see there is a scale given on the left lower quadrant, which tells us the movement of the scope, whether it is moving forward or moving backward. So here it is moving forward, you can see, and the scope slowly moves forward, and this is how a small intestine looks like. So in this patient who was around a 56-year-old male having recurrent abdominal pain, weight loss and anemia, what we found was a small bowel stricture. Biopsy was suggestive of Crohn's. He is doing well on Budes. So this is another patient with Crohn's disease. You can see some ulcers and strictures and subsequent biopsy. So with this I conclude, with high pan enteroscopy rates and good safety data even in post-surgical patients, power spiral enteroscopy is going to lead in the race. So the picture on the left hand side which shows a intraoperative enteroscopy. Previously, when we could not see full intestine from above and from below, what we used to do is operate, pull the intestine out, make a small hole and pass the endoscope through it to see the intestine. But that is the past now. The future is of power spiral enteroscopy, where you can see almost entire intestine within a very short period of time. Thank you.
Very nice lecture, Dr. Sujay. As such, small bowel is a very difficult topic. You made it very simple. With the advent of spiral, I think more and more small bowel regions will be identified.
How much does it cost?
Yes.
Cost
Cost of
spiral.
Cost of power spiral is around 70,000, 60 to 70,000. But I mean, if cost of scope you are asking,
Procedure.
procedure is 60 to 70,000.
And which way you prefer? Is it retrograde or
cheaper in what I didn't get you.
Which way you prefer?
Antigrade or
Prefer is antigrade. Prefer is antigrade. Retrograde only if you are not able to see almost entire intestine, or if you are not able to reach the desired level or the lesion, then you mark that area with the India ink, and then you go retrogradely up to that mark again, so that you have a pan enteroscopy if you don't find the lesion. If you find lesion before that, no need to go retrogradely. Or if the lesion is very distally, say in the distal ileum, then probably you will like to proceed from below.
with the advent of this enteroscopy, will the capsule endoscopy will be obsolete?
Not likely. Everything has complementary effect. All these three things, say radiology, capsule, and enteroscopy, they contribute some or other way to the patient diagnosis and then planning therapeutics. Enteroscopy is not like what a patient coming to your OPD, you directly subject him or her for endoscopy or colonoscopy. That is not the case as far as enteroscopy is concerned. You require a lot of prior evaluation in the form of CT angiography or say capsule endoscopy. So, patient is coming to you with obscure GI bleed, melena, and having anemia, intermittent melena and anemia, chronic anemia. So you would like to see what the lesion is. You will not, after say patient coming to you, will not directly subject him to enteroscopy. So you would like to see whether fecal local blood positive, then you do CT angiography, you rule out any obstructive lesions, and you push capsule, and capsule will show you some lesions, say for example multiple angiectasias. For doing APC of those angiectasias, you will pass the enteroscope. So you will have some idea. You cannot just, it's not like endoscopy and colonoscopy so that you go inside and see whatever and then you tackle that at that time. That is not the case. You have to have some plan before you are going inside, because these are risky procedures. The thickness of small bowel is just 3 to 4 mm. It's very complication prone procedures, requires a lot of training. Not everybody's job.
So we can do the biopsies, and even we can treat the lesions also during the enteroscopy.
Yes, we can do all those things what we are doing. Endoscopy, endo and colon. So polypectomies or clipping, whatever, all those things you can do. Dilatation of strictures.
And for the small bowel GI bleeds, what will be your approach? Will you do the radiological scan, or will you go for?
Two things are there. One thing is acute small bowel GI bleed. You will not have some time, that much of time. But that is a rare case. What is common is subacute GI bleed with patient may or may not have melena, usually has anemia, and such patients usually they come to you on OP basis rather than emergency. You should have first confirm. If they say melena, fine. If they don't say melena, confirm by doing FOBT that there is a GI blood loss. Otherwise, we are dealing with something else. So if there is a GI blood loss, once you confirm, you should get a CT angiography done to rule out any obstruction, and that this is mandatory. Before putting a capsule, CT angioglysis is must. Otherwise, capsule may get stuck. And once CT angioglysis is done, then we'll move on with capsule, and whatever lesion capsule shows, accordingly we can plan. Suppose capsule shows a Meckel's diverticulum, no need of enteroscopy. That is what I will. Or CT angioglysis itself shows a Meckel's diverticulum, or it shows a small gist in the small intestine. No need of capsule, no need of endoscopy. Straightway subject to surgery.
And is there any role of this angiography, this mesenteric angiography?
In case of acute, what I spoke before was, if patient is coming to you in acute GI bleed, there you don't have option of this CT enterography and capsule and all those things. There you may go with CT angio rather than CT enterography, because you want to see an arterial bleed. Acute bleed, usually arterial massive bleeds, so you want to look for put a contrast into arteries and look whether the contrast is extravasing. There you may also do, you may put enteroscopy slightly higher up than, rather than waiting for too much for this CT enterography and capsule, and probably also do intraoperative enteroscopy.
Thank you, Dr. Sujay, for giving the excellent overview, because it's a Pandora box and you have opened it very well. So, any question from the audience? Yeah. So, thank you, Dr. Sujay. It was a very good lecture.
Thank you, Dr. Purkani. May I request our President, Dr. Raju Variani, sir, Dr. Padma Iyer madam also, I request her to come onto the dais to felicitate Dr. Kulkarni. Very excellent. I request Dr. Varyani sir and madam to felicitate all the chairpersons. Please, Dr. Yadav sir, please come. Let's now go to our next lecture. And to chair this session, may I request Dr. Kaustubh Khare, consultant physician, Dr. Abhijit Karad sir, assistant professor of gastroenterology at D.Y. Patil College, and Dr. Kataria sir, gastroenterologist from Noble Hospital, to come onto the dais to chair the session. And the speaker is Dr. Sunil Pawar. He is a gastroenterologist and liver specialist. Practicing in Viman Nagar, he is a consultant at Jahangir Hospital. He has completed his medical education from Mumbai, Sion, KEM and Nair Hospital. And he was assistant professor at Nair as well as at Sassoon. And he has more than 26 publications in national international journals and has also authored a chapter in API Textbook of Medicine.
Good afternoon, everybody. I understand this is a post-lunch session. I will be very concise and very to the point. This is a vast topic to be covered in 25 minutes. So in spite of having a didactic lecture, we will see first few basic things and we'll take one case and we'll go along with case to discuss the issues. So IBD is an inflammatory bowel disease. It is a basically chronic immune-mediated inflammation of gastrointestinal tract. It is a progressive disease, it is a chronic disease. Sometimes IBS and IBD, these acronyms are used synonymously, but IBS is irritable bowel syndrome. It is completely non-inflammatory. IBD is an inflammatory bowel disease. It has two types, major two types. One is Crohn's disease and another is ulcerative colitis. There is another small entity, around 10% of the time, it is indeterminate colitis. Eventually they will turn on to either become a Crohn's disease or a ulcerative colitis. In India, around 4 to 7, the prevalence of both Crohn's or ulcerative colitis is around 3 to 7 per 100,000 person years. A recently published study which included different centers from all over India, which showed ulcerative colitis is 5 times more common than Crohn's in India. Mean age is at 37. Generally, immune disorders are common in females, but IBD, male gender is more commonly involved than female gender. there is less of family history as compared to Western studies. There is less of extraintestinal manifestation compared to Western studies, and there is a less of colon cancer incidence as compared to West. In India also, northern side has more of an ulcerative colitis patient than Crohn's, and southern India has more of a Crohn's disease. We generally we align with northern part. So as we have discussed, this is an immune mediated, there is genetic susceptibility, and what has changed over a recent period is environmental triggers. I am not surprised in next few years, maybe India will also become a capital of IBD. At this state, it is increasing in incidence. So westernization in diet, addictions, lot of overuse of antibiotics even in children, this is all predisposing to IBD. So we'll see one basic case, a first presentation of bloody diarrhea, and because this is very important, this is one of the common emergencies we all see commonly in our practice. There is definitely a diagnostic challenge if patient doesn't improve in 1 or 2 days. It affects quality of life. There is less of awareness about IBD in public, and in severe cases patient may die. So this is a 30-year-old female who had a bloody diarrhea, 5 to 6 episodes for 2 days, along with tenesmus, mucus, cramps, along with fever, and treated at primary center with antibiotics. She partially felt better, but because seeing blood in stool scares people, she came to my clinic. By the time she came, there was no fever, the frequency has decreased, but still there is blood, there is still cramp, patient is comfortable, there is no signs of dehydration. Pulse is 101, but otherwise, and apart from mild tenderness in left iliac fossa, she was okay. So this is a classical case of acute bloody diarrhea, mostly involving large intestine, colitis. So is it infection or is it IBD? So we'll not consider other etiologies for the sake of discussion. Generally, acute bloody diarrhea, 50% of the time it is because of infection, and 50% of the time it is because of non-infectious reason. It may be IBD, it may be anything else, diverticulitis, malignancies. So there are few points in history, because majority of these cases, 70% of diagnosis comes from history. Even this holds true for this case. So when onset is very acute, it is probably we are dealing with infection. If onset is insidious, probably we are dealing with an IBD. Generally, infections improve in 2 to 3 weeks, apart from some like tuberculosis or amoebic. Otherwise, rest infection improve in 2 to 3 weeks. Characteristic of stool does not give us much information about is it a infection or non-infection. Pain, there is a colicky pain in both infection and IBD, but if it is continuous pain along with an colicky add-ons, maybe mesentery has involved and probably we are dealing with an IBD. Vomiting also will not give us much, but if severe vomiting is there, probably infection. If group of people is affected, probably we are dealing with infection. If patient is very sick looking on day 1, probably we are dealing with infection. If you are fortunate enough to get a patient with acute bloody diarrhea with extraintestinal manifestations, then probably more easy to diagnose inflammatory bowel disease. Also mind, there is a reactive arthritis after an infectious colitis, so this may also confuse sometimes. Travel history, a lot of people come from, they go to Konkan, they to Goa, they Mahabaleshwar, and they come with bloody diarrhea, most likely infections. Same applies to street food. Now, if fever is there, very high grade fever on day 1, probably we are dealing with infection. If fever comes after some days of bloody diarrhea, maybe we are dealing with an inflammatory bowel disease. These 2 points I want to highlight. Even if there is no bloody diarrhea and in past history, if patient has an intermittent diarrhea, maybe after few months, non-bloody, this may also be a case of inflammatory bowel disease. So recurrent diarrheas we should always evaluate. Secondly, PR bleeding. Many patients come to us with operations for piles has been done, some pile banding has been done because of intermittent PR bleeding. So if on history, if there is no hard stool, if there is no lot of straining and still the blood is there, probably we need to evaluate rather than go for piles operation. If there is a family history of any autoimmune disease, IBD, probably that will also help. If patient, definitely we need to evaluate immunosuppression, sexual history, and some medicine which can cause an colitis-like symptom like NSAIDs and some anticoagulant. So, in nutshell, ulcerative colitis involves colon and rectum, whereas Crohn's can involve anything from mouth to anal area. In ulcerative colitis, rectum is always involved. In Crohn's disease, it is not the case. In ulcerative colitis, it is a mucosal and submucosal injury, and in Crohn's disease, it is transmural, whole of the bowel wall is involved. Ulcerative colitis, continuous pattern is seen in involvement, whereas in Crohn's, it is a skip areas. So, no, ulcerative colitis can involve either rectum or rectosigmoid or left side colon or more than that. But symptom probably apart from no intensity of symptom, but they will have rectal bleeding, cramps, tenesmus, urgency, mucus in stool. And in Crohn's disease, it depends because it is pan GI involvement may happen in Crohn's disease. So depending upon a phenotype and characteristic pattern of the disease, if it is an inflammatory kind of disease, then maybe like ulcerative colitis symptom they have. Or if it is a stricturing kind of disease, patient may present with subacute intestinal obstruction. One more point here, subacute intestinal obstruction does not always require vomiting to be present. It may be just pain, some distension which improves. So that also we should keep in mind. If penetrating disease is there, there are abscesses and fistulas including perianal area. Coming to our case, her WBC count is 10,000. This is not, probably this is because neutrophil counts is also normal. If this WBC count would have been some 15,000-18,000 with high neutrophil, then maybe more of an infectious. Her hemoglobin is 9, which also favors chronicity. Platelet is more, which favors chronicity. Albumin is low, which favors chronicity. Now, many times we do ER, ESR, CRP, and calprotectin, but they will not help us to differentiate between an IBD and infection. Stool report, apart from if we see a trophocytes, then probably it is amoebic, but otherwise, having some pus cells, RBC, mucus will not help us to differentiate between an IBD and infection. Sonography, same applies. It doesn't help us to differentiate between is it infection or is it IBD. So this is how a normal colonoscopy, colon looks in colonoscopy. So in infection, there are some patchy ulcers, patchy erythema, some very small punctate ulcers. So this is a classical punch-out ulcer seen in some viral infections. This is how amoebic colitis looks with patchy ulcers with edematous folds. This is how C. difficile infection looks, especially in immunosuppressed, also in old age patients with antibiotics received. In ulcerative colitis, what we see is this is a milder ulcerative colitis patient with loss of vascularity, there is granularity, some friability. In severe cases, we may see ulcers. So in histopathology, amoebic colitis may have no, amoebic colitis generally have zero inflammation. We may see a flask-shaped ulcer, we may see a trophocytes also. No, in CMV we may see intranuclear inclusions. In ulcerative colitis especially, we see a basal plasmacytosis, which is a very early sign. Only having crypt abscess or cryptitis is not enough. We need a crypt distortion, crypt structural problem, structural deformity we need. So this patient, our patient, has a classical colonoscopic finding of ulcerative colitis. So how we approach a diagnosis of IBD? First, we want to differentiate between Crohn's disease and ulcerative colitis. We want to know the extent of disease. We want to identify the behavior, especially in Crohn's disease. Is it a stricturing disease or is it a penetrating disease? We want to know the severity of disease. There are different scores for it. There is no gold standard test for diagnosis of IBD. It is always a combination of history, examination, laboratory findings, and an endoscopy findings. So the diagnostic algorithm generally followed is laboratory test, stool test, and then we go ahead with an ileocolonoscopy depending upon symptoms, upper GI scopy. If ulcerative colitis is there, it is straight away we can treat it. If the picture is like Crohn's disease. I will come to it in short. Then we need to get evaluation of small intestine also to know the extent. If ileocolonoscopy and upper GI-scope is normal and still we are suspecting, we may go for CT enterography or capsule endoscopy if that is also normal. So this is in Crohn's disease. The left upper we see normal mucosa. In middle there are ileal ulcerations, and there is middle down. There is aphthous ulcers in middle down photo of ileal. So these aphthous ulcers can be non-specific and can also be in Crohn's disease. So histopathology will guide us more. In right lower there are longitudinal deep ulcers which are very classical of Crohn's disease. In Crohn's disease there is a transpleural inflammation and there is a granuloma. So the goals of treatment in IBD is first to induce a remission, to turn off inflammation, make laboratory findings normalize, make patient symptomatically better, then maintain remission with try to reduce and stop steroid, shift them to immunomodulator, and to early diagnose the relapse and monitor side effects of therapy and monitor cancer prevention. So the medication that works best for your patient is the one patient is taking consistently, because this is a chronic disease, patient needs to take medicine. So we cannot go in detailed discussion about treatment, but this is how there are two approaches of treatment. One is step up approach and another is step down approach. Step up approach is generally used in ulcerative colitis, where induction is remission is done to mesalamine or sulfasalazine along with steroids. Then they are slowly, then steroid is slowly tapered and patient is, depending upon severity, may be shifted to immunomodulators with azathioprine, and then patient is monitored. If there is a refractory disease or if patient is relapsing frequently, maybe we may consider biologic agent, and lastly we may consider surgery. There is one new molecule, targeted small molecules, which has come recently, tofacitinib. So that is an oral molecule, and they are quite effective in dealing with ulcerative colitis, still not approved for Crohn's disease. In Crohn's disease, depending upon a symptom, if it is a stricturing disease or penetrating disease, we may use a top-down approach, where we may start with biologics and then taper down. So the approach is different in ulcerative colitis and Crohn's disease. Now our patient has a very classical finding. First episode of bloody diarrhea, responded well to steroid and mesalamine. But wait, story doesn't end here. As in all chronic diseases, there is one smart relative or smart friend which will tell the patient to stop medicine and go to alternative medicines. She was better for 2 months after stopping medicines, and she then developed a lower backache and right knee pain and swelling. She went to orthopedician. She was started on some medicines, and she started increasing her stool frequency to 3 to 4 per day, this time semi-solid, non-bloody. Now, the natural history of ulcerative colitis, majority of ulcerative colitis will have a severe presentation initially, and then the intensity of symptom decreases. But in very few patients, the initial presentation may be very mild, but later on the severity of disease increases. There is a chronic intermittent symptoms, and there is a chronic continuous symptom. So the history of each and every ulcerative colitis patient may be different, and it is not the universal. In Crohn's disease, same chronic intermittent symptom may happen, or if there is a stricturing disease, patient may underwent the surgery, then again repeat surgery, other agent repeat surgery. So the disease course may be quite destructive and destructive for patient. So these extraintestinal manifestations what our patient had after stopping medicine is a lower backache and arthritis, knee arthritis. So extraintestinal manifestation can happen with the, they can happen along with severe disease, or there are some extraintestinal manifestation which can happen even if disease is in remission, like liver diseases, gallbladder, thyroid disease, alopecia areata. These can manifest even if disease is in remission. So there are abscess ulcers, there is pyoderma gangrenosum, there are erythema nodosum, episcleritis, uveitis, sacroiliitis, which our patient had sacroiliitis, and arthritis. These all can present with or without disease severity. One last slide about TB versus Crohn's disease. It is a very confusion many a times. There is still evolving data to differentiate. Some patients we still stumble and we may have to start them an empirical AKT. So there are various differentiating points, but few which I personally find is useful is granulomas, if any found. The small granulomas are characteristic of Crohn's disease. So we should ask the pathologist to mention if granuloma is small or large. Secondly, if there is a non-caseating granuloma that favors Crohn's, and if lymph nodes are very small and non-necrotic. Same applies in imaging. Imaging, if there is a loss of stratification, stratification means we can see, suppose in CT scan, we can see each layer of wall separately, like mucosa, submucosa, muscularis propria, serous, everything we can see separately, then probably we are dealing with Crohn's. But there are limitations to this also. Comb sign, where there is a various vascularity of mesentery has increased. That is a characteristic for Crohn's disease. So in some other cases it is seen, and abscesses definitely. So there are very important takeaway points I want to in nutshell tell again. So infective colitis generally resolved in 3 to 4 weeks. There is challenge to diagnose first episode of IBD from infection. IBD patient sometimes respond to antibiotic because infection may have triggered their IBD. So they respond to antibiotics and we may feel they are infection and not an IBD. Intermittent PR bleeding is not always wise. We have to go into history. Extraintestinal manifestation may manifest even in remission, and patient may sometimes present with a monoarthritis, single joint arthritis, or a sacroiliitis, and later on they may develop onto symptoms of colitis. TB versus Crohn's, still confusion haunts in some cases, and there are quite a newer research has made life more easy for IBD patient. Like previously, we used to say for any ulcerative colitis or Crohn's disease patient, you can eat anything. But now there is a very exciting data, exciting research is going on about diet. There is an anti-inflammatory diet. So maybe data will come up in few days. As in NFAD, we thought of Mediterranean, we listened to Mediterranean diet. So that also helps in IBD. But data is coming and will soon come to know about it. And in IBD, long-term care is needed. Thank you very much.
Thank you very much, sir, for such a vast topic to cover in a short period of time. Sir, you have spoken about how to distinguish between IBD and infective diarrhea. Also, you have spoken to distinguish between Crohn's disease and tuberculosis. Particularly Crohn's and tuberculosis, even after doing many tests, there are a lot of similarities in clinical presentation, CT findings, and even endoscopy, and dilemma persists even after histopathology. So I want to know how you practically approach such cases.
See, generally, because nowadays we always take a gene expert and MGIT culture for tuberculosis, histopathology as usual we take. TB PCR is not generally done. If it is clearly we found anything in positive, like in gene expert we find positive, or if in MGIT we grow tuberculosis bacteria, then it is straightforward. Secondly, if all this histopathology is not helpful, gene expert is negative, and MGIT is also negative, it takes some time. This time we go on imaging basis. If there are necrotic lymph nodes, if there are no necrotic lymph nodes, if lot of patchy involvement is there in small bowel, if there is a past history as we discussed in all history points, then probably I will start them. And if patient is on low socioeconomic status, that also we take in consideration. So if patient is from low socioeconomic status, we may start him on empirical AKT first, and then repeat colonoscopy after 9 months. When we start AKT, we give AKT complete for 9 months. We don't stop at 2 months and do colonoscopy to see if there is an improvement or no improvement and then decide. And secondly, I generally don't give both treatments simultaneously with steroids. And if I have decided that I am going to treat this patient as COX, I will treat them as COX, and then I will do repeat colonoscopy at 9 months. Still ulcer persists, then I may shift to cross disease treatment.
Thank you very much, sir. One more question, sir, regarding the formulations of mesalamine. They are different from formulations to be used in ulcerative colitis based on the area involved and Crohn's disease. Can you specify some of them?
See, mesalamine, now there are MMX technology with mesalamine, there are granule formations with mesalamine, and there are tablet formations with mesalamine. Tablet formation with mesalamine disintegrate and activates only in large intestine. So all colonic diseases, we can use tablet form of mesalamine. They are available. Granule forms are generally used in small intestine along with large intestine. So granule forms, if there is a Crohn's disease which is involving proximal ileum, we use granule forms. And MMX technology is used in both forms, either in small intestine as well as in large intestine. Granule forms also helps for colonic, but if there is a pure colonic disease, I prefer tablet.
Thank you, sir, for such excellent lecture. Even though you have mentioned that there is still data coming about the diet of the ulcerative colitis and Crohn's disease, but still, as we are seeing the patient on daily basis, and patient eventually asks you about what are the things he should be consuming or which he should be avoiding. What is your routine advice to them?
I advise them to avoid spicy foods. I advise them to avoid outside food as much as possible if they want to, because it is a common to go outside. I advise them to take only yellow dal and rice. Secondly, I advise them to avoid emulsifiers as much as possible, preservative as much as possible. So at present I am advising this only, but there are quite exciting data coming on diet. Maybe in next few years we'll see a lot of dietary advices specifically for different for ulcerative colitis and different for Crohn's disease also.
What are emulsifiers?
See, emulsifier, we eat mayonnaise sauce. It is very commonly used. So mayonnaise in original form we cannot see also, let alone testing it. So what we use in mayonnaise, that is emulsified in. Ice cream has emulsifiers. So lot of things has emulsifiers. We even don't think of added preservatives before eating so many things. We have chips we have, those are emulsifiers. Yeah?
Emulsified fats.
Emulsifiers are different. Emulsifier fats are also there. A lot of other things are. So we don't think before buying chips. We don't think those way, because this westernization has caused a rapid increase in incidence of IBD. Maybe in a month we see 10-15 patients of new cases of IBD. So we will become a capital of IBD in maybe few years, not decades, but few years only.
Thank you, Dr. Pawar. Any more questions?
There is one more question. If we have time, we can take it.
Okay, last question.
To catch the IBD patients at early stage, is there any definite biochemical marker or any investigation?
I didn't get your question.
To catch these IBD patients at an early stage, is there any IBD marker or is there any investigation which can detect these IBD patients at an early stage?
See, because it is a history which is most important. We cannot go on to do investigation without the symptom. So history is most important. We have to, if there is a diarrhea, if patient utter a symptom of loose motion, diarrhea, we have to go in detail of those things.
So IBS.
Thank you, Dr. Pawar. May I request our President, Dr. Raju Variani sir, to come onto the dais. Also, I request President PPDA, Dr. Kapil Jagtap sir, to come on the dais, please. And Secretary, Dr. Shinde sir. request Dr. Variani sir to felicitate Dr. Kataria and Dr. Karad, please. Please.
संपलं चला बाहेर
I request Dr. Shubhada Joshi, please come up to the dais.
वाढून घेतले का का असं केलं पण त्याने त्याच्या आपण बघतोय दुसरं कोणी असेल तर वाटेल खरं तुला असतील बघायची
Yes.
पहिल्यांदा म्हणलं की वाटते मस्त
I request Dr. Kedar Patil, Honorary Secretary of IMA Pune, to come on to the dais to conduct the panel discussion. Till they are doing the arrangements, in the upcoming programs, I would remind you once again of 24th May webinar, which is online. 18th June there is CME. Also on 13th June, there is free camp, health checkup camp for all the Varkaris who would be coming in Delhi. So those IMA members who wish to give their services, the camp will be in these premises only, so you're most welcome. Also on 21st of June, it is the International Yoga Day. On this occasion, we have a special yoga session by Yoga Guru and a physician, Dr. Manoj Naik. So I request all of you even to join for that. And from 28th May to 4th June is IMA Pune's Foundation Week celebration. So there are various programs, like there is stand-up comedy, there are talent show, there is talent show of IMA members. So you all can enjoy. But most important is there is a special program by Kamayani's Special Children. That is on 28th of May at 4 o'clock. So I request all of you to come for this program and to encourage the children and especially the parents. Thank you. Over to you, Dr. Kedar Patil.
Just to highlight what she mentioned, we have a leather ball cricket tournament. This is the second year we are doing it. We have 8 teams across Pune, almost 120 doctors participating. And I would encourage all of you to come at Nehru Stadium on 26, 27, 28 as per your convenience. 8:30 AM is the inauguration on 26th and prize distribution is at 4 PM on 28th. Thank you. With this, we start the panel discussion, last presentation and last discussion on this meet. We have with us panelists Dr. Dadasaheb Maindad, Dr. Vivek Murumkar, Dr. Prasad Bhate. Dr. Dadasaheb and Dr. Vivek have been introduced earlier. Dr. Bhate is a gastroenterologist at Aditya Birla Hospital, Pune. Dr. Samrat Jankar is a friend and he's a GI surgeon from Symbiosis Medical College. And Dr. Suhas Udgirkar from Jupiter Hospital, Pune. With this, I hand over the proceedings.
कुठे रेंजच उडली काय झालं
गुड इव्हनिंग गुड आफ्टरनून सगळेच जण थकलेत आणि मीही थकलोय प्रोग्राम ऑर्गनाइज सो वी विल मेक इट अ शॉर्ट पॅनल डिस्कशन ऑन गॅस्ट्रोइंटेस्टाइनल ब्लीड. So gastrointestinal bleed basically divided into two categories, upper GI bleed and lower GI bleed. it is seen 80 to 150 per 1 lakh population, and mortality and morbidity is up to 2 to 15%. More common presentation, what we are seeing in day-by-day practice is hematemesis, hematochezia, melena, undiagnosed anemia, and shock. So here is a case, 40-year-old male, presented with hematemesis 4 episodes. Blood pressure was 90 by 15 millimeter of mercury. Pulse rate was 125 per minute. He is icteric. History of chronic alcohol consumption was there. Last drink taken 1 day prior, and he was conscious and oriented. So Prasad, what is your probable diagnosis?
Voice.
Now you can hear. So at the onset, I would like to thank Dadasaheb for organizing such a beautiful event. And at the last session, such a huge crowd is present. So I like to thank all of you to be patient and hearing all these discussions. And I have seen everybody actively participating in the question and answer session. So thank you very much, Dadasaheb and the audience also. So in this case, he's a middle-aged man with history of chronic alcoholism with icterus. Most likely he has a chronic liver disease, liver cirrhosis, portal hypertension, and variceal bleed.
Any other possibility?
Again, alcohol is also gastric irritant. There can be a gastric ulcer which may have bleed.
Okay, then Mallory's tear can be there because he had a history of 1 day prior alcohol consumption. As Prasad told, there could be a alcoholic gastritis and variceal bleed, either esophageal or a gastric variceal bleed could be there. So variceal bleed is our diagnosis. So what are the treatment options there to control the variceal bleed?
So patients who are presenting first time as a variceal bleed, we should first manage it by medically to stabilize the patient first for 12 hours by giving IV fluids, that too rigorous IV fluids in the form of extragenous IV fluid resuscitation is not required. Patient should be stabilized with BP of around 100 systolic, pulse rate of less than 100, and patient should be given blood products to maintain the blood of hemoglobin between 7 to 9, preferably with 7. Again, giving too many blood products to increase the hemoglobin more than 9 are not required. Once the patient is stabilized in the form of basics of ABC, airway, breathing, and circulation, then such patients can be considered for diagnosis and treatment by endoscopic methods. Once the patient is stabilized, preferably after 12 hours, because previous studies showing taking patient immediately for endoscopy doesn't help. Let the patient stabilize by doing all these preventive or primary methods, and then patient can be taken for endoscopy.
So first is as a rule ABC, that is we have to maintain the patient's airway, breathing, and circulation. Resuscitate patient with crystalloids and transfuse blood. Target hemoglobin is 7 to 8 gram per deciliter. More blood transfusion will cause increase in the portal hypertension and excessive bleeding will be there. So our target blood pressure should be more than 90 to 100 millimeter of mercury. Pulse rate should be less than 100 and central venous pressure should be between 1 to 5. The platelet and FFP should be transfused as per need. Antibiotics are very important, and we should advise, we should give the antibiotic in all cirrhotic patients because there is chances of infection from 40 to 60%. RT insertion is not advised routinely. So Prasad, when you will advise to transfuse platelet and FFP?
So actually, when there is active bleeding present, platelet INR should be connected. It should be less than 1.5. So if your values are INR values are more than 1.5, at least 15 ml per kg of fresh frozen plasma should be given. For platelets, we tend to keep it above 50,000. If it is 80,000 or 1 lakh, I usually try not to give single donor platelets. But if it is less than 50,000, definitely single donor plasma is much better than the random donor plasma.
So there is still no any concrete guideline when to transfuse platelet or fresh frozen plasma in the patients with variceal bleed. There are a lot of controversies, but it is considered that if platelets are less than 50,000 and if INR is more than 1.5, we have to transfuse the patient, and this transfusion should be given before procedure. So, Suhas, what are the scoring systems which will guide us for the severity of bleeding?
Most commonly, scoring system which we are using are ROCAL score, which is most commonly pre-endoscopy and post-endoscopy score. Then other most commonly used parameters, again multiple scoring system which are using the same parameters like blood pressure, heart rate, amount of blood loss, the patient's respiratory rate, and the mental status. All these parameters which give us the basic guidelines regarding the patient status, which we already discussed that patient's general condition has to be stabilized first, and then such patients, according to the severity, according to different scores, can be taken for endoscopy and further therapies. But ROCAL score is which we previously, but these are very complex scores which cannot be calculated without taking any calculator. So such or M65 is another score which can be used. But I think in day-to-day routine practice, general condition of the patient should be looked after rather than going further all these scores.
Yes, patient's blood pressure and pulse rate is very good guide to assess the severity of bleeding. And American College criteria for amount of blood loss is there. It is very easy criteria we can diagnose on the routine parameters. And with this scoring system, we can assess the patient's severity of bleed, and according to that, we will take action. So, Prasad, what are the common causes for the GI bleed?
So, the most common causes are of GI bleed are gastric and duodenal ulcers followed by variceal bleed. But it depends on the center where you are working. If you are a gastric referral center where the hepatologist is present, then the variceal bleeds are more common. Nowadays, with the use of PPS, the epidemiology of GI bleed is changing. So, esophagitis and gastric ulcers and duodenal ulcers are becoming lesser and lesser. But the most common causes are these three: gastric and duodenal ulcers, variceal.
And mass gastric and duodenal ulcer bleed is the etiological factor for upper GI bleed in 15 to 25% of the patients. So many times when patient is coming to us in emergency with GI bleed, immediately we will put the rinse tube, we will give the cold saline wash or some saline wash. Is it really indicated, Suhas?
Cold saline wash, again there is controversy, but as far as possible we don't refer such patient with cold saline wash. We sometimes, when there is only melena, we try to put the RT to see whether active blood is there in stomach or not. We try to aspirate blood from the stomach just to confirm that there is active GI bleeding which is going on. But to give sometimes when there is less time, then giving wash helps in clearance of the content from the stomach. But again, there is controversy regarding whether to give such wash or not.
Nasogastric tube insertion is a controversial point, and it is only indicated in the patients those are having ongoing fresh bleed. There is no any role in patients who are having coffee ground blood in their vomiting, and it will help us to assess the ongoing bleed when we will attach our RT to the drain bag. It will help us to give the wash. What are the disadvantages of RT insertion is, if there is no blood in RT, it doesn't mean that there is no upper GI bleed, because if bleed is from the duodenum, then RT will be clear. It causes patients uncomfortable, and chances of aspirations are more with RT insertion. So, Prasad, can you explain what are the pharmacotherapies and drugs used before the endoscopy or with endoscopy to control the variceal bleed?
So when the patient is in the emergency room, we actually don't know whether it is variceal or non-variceal bleed. So it is always prudent to start a PPI infusion or give at least high dose pantoprazole or esomeprazole, which actually increases the GI pH decreases the acid and stabilizes the clot. Then we give, if we are suspecting variceal bleed, terlipressin is the drug of choice, which is given in the bolus of 2 milligram. Like it is given as stat, but what we practice is give it in 100 ml of NS over the period of 20 minutes. It decreases the portal pressure and decreases the variceal bleed. Other alternatives are somatostatin and octreotide. Somatostatin action is very short and terlipressin has many advantages over somatostatin. So in India, terlipressin is used. In US, where terlipressin is not available, the somatostatin analog, that is octreotide, that is used. It is given as 50 microgram bolus IV and then 50 microgram every 6 hours. If in the emergency room terlipressin is not available or patient is not affording, octreotide is a cheaper option and the action are equally good.
So there are a few drugs. Terlipressin we can start from 1 milligram and increase up to the 2 milligram. We can use it as a bolus or infusion every 4 to 6 hourly. Success rate is as good as endoscopy, that is up to 80%. Somatostatin, octreotide, norepinephrine and vasopressin are the other option. Terlipressin continuous infusion is better than the bolus. And what infusion we have to give is the 8 milligram per day. So if we want to give the bolus, the requirement is, if we want to give the infusion, the requirement is 4 milligram, and if we want to give the bolus, requirement is 8 milligram per day. So again here we will save the cost. It reduces the portal pressure more with the infusion and lesser side effects. So what is the best time for endoscopy? So and if we will consider the early endoscopy, is there any disadvantages?
There has been a discussion on whether ideal time is again after stabilization, preferably at 12 hours, 12 to 24 hours. Earlier for emergency endoscopy, that is up to 6 hours of patient presentation, has previously been studied in various studies. But in such patient, when the patient is unstable, chances of aspiration, chances of sudden death have increased in such patient when patient was unstable and still was taken for endoscopy. So when it was studied for head-to-head comparison for mortality and endoscopic hemostasis was the criteria, then there was no head-to-head difference, or 12 hours endoscopy was slightly better than what rather than a 6-hour endoscopy. So first and foremost is stabilization and then take for endoscopy maybe at 12 hours.
So pharmacotherapy is as good as the endoscopy, so we can start the pharmacotherapy and we can delay the endoscopy for a few hours. If patient is hemodynamically unstable, then we have to take patient as early as possible. There is a lot of controversy regarding the time of endoscopy. If the patient is stable, few guidelines says that 6 to 24 hours is a good time for the endoscopy. ASLD says up to 12 hours is the good time for endoscopy. If we will do the endoscopy very early, in that case our vision will be hampered. We will do the lot of endotherapy. We will not able to identify the lesion. We will not able to identify the bleeding sites, as well as at same time aspiration and shock can increase and mortality will be high. So that first pharmacotherapy, stabilize the patients and go for the endoscopy. If patient is unstable, then only emergency endoscopy is advised. Once patient is treated with the pharmacotherapy or endotherapy, we have to consider the prophylaxis. So Prasad, what are the drugs available for the prophylaxis?
So non-selective beta blockers such as propranolol and carvedilol and nodelol are routinely used. We can also use carvedilol for this purpose. If we start treating patient before they bleed, it's called as primary prophylaxis. After doing endoscopy for bleeding, after banding, if we start, it is called as secondary prophylaxis.
So primary prophylaxis are two types. Either you can band the varices or either you can treat with the drugs, and both are having equal effect and both are having equal success rate. But beta blockers, what we are non-selective beta blocker, what we are using for the prophylaxis, in addition to the controlling of variceal bleed, it reduces the portal hypertension, and your multiple literature says that beta blockers are little bit better than the endoscopic band ligation. And in secondary prophylaxis, either you always you combine endoscopic band ligation and non-selective beta blockers. because single therapy is having less success rates as compared to the combined therapy. If you will compare the terlipressin with other drug like octreotide, somatostatin, Suhas, what will be your opinion?
Comparison of terlipressin with other drugs, the efficacy was same except for the mortality benefit which was more found with terlipressin. Other than that, the head-to-head comparison had similar efficacy in controlling the bleeding rate. Mortality benefit was more with terlipressin. Hence, wherever possible, when there is no contraindication like there is no arrhythmia, there is no shock, or there is no hyponatremia, then terlipressin is always better, and when there are no financial constraints.
So many studies says that there is no much difference between the terlipressin and octreotide or terlipressin and somatostatin. There are little bit difference which is not statistically significant.
Sunday, Saturday नसते.
What is the endoscopic management modalities for variceal bleed, Prasad?
Endoscopically, there are two things. We can do sclerotherapy or banding. Banding has less side effects, so banding is the preferred modality. Except when when the mouth opening is low and we cannot insert the band into the esophagus, then only we use sclerotherapy. Another modality, if the banding and sclerotherapy fails, then we can use Danny-Zella stent, which is the esophageal stent which physically compresses the varices.
So for the esophageal variceal bleeding, endoscopic band ligation and sclerotherapy are two approved therapies, and for the gastric varices, again band ligation, cyanoacrylate glue and UVS guided coil embolizations are the other therapies for the gastric varices. In endoscopic band ligation, we will apply the rubber band over the varix, which will cause the inflammation and thrombosis of the varix. Success rate is around 80 to 90% in both endoscopic band ligation and sclerotherapy. Treatment with endoscopic band ligation or sclerotherapy is as good as pharmacotherapy. So as Prasad said, that endoscopic variceal band ligation is better than the sclerotherapy. It's having less side effect. Typically 5 to 10 bands are applied over 5 to 8 centimeter over the gastroesophageal junctions, and usually we have to apply each band 2 centimeter apart, and repeat banding should be considered after 4 weeks. There are different drugs for the sclerotherapy, that polydiconol, sodium morate. These drugs we can use for the sclerotherapy. There are two types of sclerotherapy. Either we can inject into the varix directly, that is intravaricial or paravaricial. First we have to inject 2 ml below the bleeding spot, and then we have to inject 1 to 2 ml around the varix, so that it will cause the thrombosis of the varix and the bleeding will stop. So Suhas, if we will compare endoscopic band ligation versus sclerotherapy, what is your opinion?
Nowadays, keeping us the data apart, nobody uses endoscopic sclerotherapy until it is very much required. When the varices are very small, they are less than small varices where band causing more ulcers, or band could not be applied, or there are previous history of band where the underlying mucosa is very stiff and scarred. In such cases only we use sclerotherapy. Those sclerotherapy causes more frequent ulcers, but they are small. EVL causes there are less number of ulcers, but they are large ulcers. So each has some good points and bad points, but nowadays when EVLs are available, sclerotherapy is only used when EVL cannot be used.
Sclerotherapy used only in the small ulcers and when ligation is difficult. The failure rate with sclerotherapy is more, it is up to 50%, and again mortality and complications are more with the sclerotherapy. So band ligation is the first choice for the acute variceal bleed. When sclerotherapy, what are the benefits? The sclerotherapy is having many side effects, but what are the benefits? It is easy to perform. Then it can be done in a poor region, so you will not, there is no need to localize the lesion. You can just go below the bleeding spot and inject it. And disadvantages are substernal pain, fever, dysphagia, pleural effusion, bacteremia and ulcer. So these are the picture for the sclerotherapy and band ligation. In the first picture there is a sclerotherapy needle. We are puncturing the varix and we will inject the sclerosant. In second picture we are banding the varices with rubber band. So as when you will call failure to control the bleed?
There is a when there is a recurrent bleed within 12 or 24 hours of the first band session, or when there is a drop of hemoglobin by more than 2 gram in 12 hours, or when there is a recurrent massive bleed requiring more than 4 units of blood transfusion, then we call. But in such cases also nowadays what we use criteria which is more useful and practical is when there are 2 endoscopic procedures done 12 hours apart, when they are not effective, still the patient is bleeding, then we normally call it as endoscopic failure or failure of pharmacological or endoscopic procedure also.
Right. So this is a little bit bookish method what we displayed here in the slide, but very easy definition is there. When we are unable to control the bleed with pharmacotherapy and 2 endoscopy sessions, then we will call it as a failure to control the bleed, and in that situation we have to use the rescue methods to control the varicose bleed. So what are the rescue methods, Prasad?
So if SB tube is available, that is the tamponade method. It has 2 balloons, gastric balloon and esophageal balloon. We can insert that SB tube bedside without need of any endoscopy. So what we do is we lubricate the tube and push it through the nostril into the stomach. We inflate the gastric balloon, pull it out, take the X-ray to make sure that the lower end is in the stomach, and then fully inflate the tube. Most of the times only inflation of gastric balloon will stop the bleeding. 2 things are important, that we have to be 100% sure before inflation that the lower is in the stomach and the tube should be available in the hospital. Another method which now we can use is Danny stent, which is a self-expandable covered metallic stent. It physically compresses the varices and stops the bleeding. If these 2 methods are not available, or if these 2 fail, then we have to refer this patient for tips to the interventional radiologist.
So Seng station Blackmore tube is the option, which is having 2 balloons, esophageal and gastric balloon, and success rate of to control the bleed is 85%, but it will require practice. Nowadays, I don't think gastroenterologists are using this, because easy method is available to put a cover stent, which is having more success rate is about 93%. Other rescue methods are hemospray and tips, but they are not well, hemospray is not well studied in the esophageal varicose bleed. Tips is always helpful, and we will require the help of interventional radiologist. So this is a Seng station Blackmore tube having 3 channels. 1 channel is for the gastric balloon, 1 channel is for the esophageal balloon, and 1 channel is for the aspiration of gastric content. Other picture shows the covered stent, which is called Danisella stent. We can put it, it will compress the varices and control the bleed. So what is the treatment for the gastric variceal bleed, Suhas?
Treatment for gastric variceal bleed again in India or except for in USA where glue is not available. This is called as glue, which is a medical glue which is formed from the cyanoacrylate material, which when comes in contact with the blood, it ionizes and forms a mesh, and then blood gets clotted in that. So this is another method by which we can put a medical glue through a catheter directly into the varices, which is called as endoscopic glue injection, which we routinely use for that is gastric varices, and which has proven efficacious in where the varices are around 1 to 2 centimeter. So endoscopic glue is one of the therapies. But when the varices are there in the other sides of the stomach, other than in the fundus, there in some rare cases endoscopic band ligation also can be possible, where the bands can be applied at a place which is feasible for band ligation.
So small gastric varices we can band. For the larger gastric varices, cyanoacrylate injection is the best method. Success rate for the glue injection is 94%, and endoscopic band ligation is around 80%. Rebleed chances is more with the band ligation. Prasad, what is your experience with US guided coil embolization in gastric varices?
So if we have very large varices which are repeatedly bleeding, and we cannot inject more glue in the single varix because it may embolize and cause pulmonary embolism. So at that time we have to insert coil by endoscopic ultrasound method and then inject glue, so that coil traps the glue and prevents embolization. So if the varix has multiple feeders and the varix is large, US guided coil followed by glue injection is the best method to stop this, to treat this bleeding.
So US guided coil embolization success rate is around 95 to 100% with minimal complications around 10%. So what happened till these presentations? 3 gastroenterologists are discussing the case of esophageal varicose bleed, and surgeon and interventional radiologists are waiting for their turn. The same thing happens in hospital also. we will try, and then we will send patient to the interventional radiologist or surgeon. So Dr. Murumkar, as an interventional radiologist, how you will help to control this bleed, varicose bleed?
So we have a lot of the 3 options, particularly for the varicose bleed control. So if, as sir rightly said, bleeding esophageal varices is not controlled by multiple sessions of the endoscopic treatment, maybe it's a BBL or it may be sclerotherapy, we have to consider patient for the TIPS. So TIPS is basically a artificially created shunt to decompress the portal's blood pressure. So we go from the jugular vein, from the hepatic vein we puncture the portal radical, and we create a shunt from the portal vein to systemic circulation. Effect of the TIPS shunt, the portal system will be decompressed, so pressure on the bleeding varices will be reduced and it will control the bleed. But TIPS, as we are producing one portal systemic artificial shunt, it do have some disadvantages, like it can cause a hepatic encephalopathy because ammonia will not be metabolized in liver, straightforward will go to the brain and will cause encephalopathy. And second, with TIPS also, there are chances of the bleed with the low pressure system also. So for such cases, where like particularly for the gastric varices, if there is a gastric varices, the other viable option is the BRTO, that is balloon retrograde transvenous occlusion of the varices, and this similarly modified into plug assisted or coil assisted. So in that, this BRTO is a viable option for the bleeding gastric varices, not amenable for the endoscopic or failed endoscopic attempt. But again, it does have some selection criteria. For the patient to undergo BRTO, the splenic vein, portal vein should be pregnant. There should not be a high risk esophageal varices, and there should not be a gross ascites. So, and there should be the varices should be decompressing into the linear shunt. So our approach is from the renal vein. From renal vein we candidate the stump of the varices which is draining into the renal vein. We occlude temporarily with the balloon or maybe with the plug and inject either gel foam or a Sectrol solution, allow it to settle for some time, and then after the next day, if you are doing BRTO, it requires 8 to 12 hours, and after that we'll just deflate the balloon and see the result. So last option for this particular case, that is a partial splenic artery embolization. This is particularly helpful because these patients are cirrhotic, spleen is grossly enlarged. Long-term sequestration of platelets in spleen will cause hypersplenism and the low platelet count, which will not respond to multiple transfusion of RDP or single donor platelets. So by embolizing the splenic pulp up to 60 to 80%, it will increase the platelet count, and increasing platelet count in turn reduces the bleeding risk. So these are the 3-4 options we have for the controlling of the variceal bleed.
So BRTO, TIPS and partial splenic artery embolizations are the options from the interventional radiologist. For the left side portal hypertension, patient is having gastric varices with patent splenic vein and splenogastric shunt. Splenogastric shunt, in that case BRTO is an option. For the variceal bleed, I think TIPS is a good option, right, Murumkar? Yes. So in TIPS, we will connect the portal vein to the hepatic vein. They will put the one covered or uncovered stent. Most of the time you are using covered stent, right?
Combination of these things, sir. There is a hybrid stent.
Hybrid.
So when we are going traversing from the parenchyma, that part has to be covered, and the ends into the portal and the hepatic ends should be a uncovered segment.
Okay. So mortality is how much is the mortality in these patients usually? What are the side effects or complications with?
So mortality is, as rightly said, around 15 to 20% mortality with TIPS also, because with TIPS we are exposing ammonia directly to the systemic circulation. So definitely patient will have risk of the hepatic encephalopathy, and with the TIPS also low pressure varices do bleed. So I'll say that success rate is about 80 to 90% and mortality is about 50 to 20%.
So usually these patients are comorbid and they are sick with malnourished. So surgical options are less. Samrat, but still suppose interventional radiologist is not able to control the bleed, how you will help us?
In variceal bleeding, role of surgeon is always limited at the end when nothing is working,
and already patient is sick, there is an attempt to salvage the patient, to save the patient. Option available in emergency bleeding condition is there may be emergency shunt procedure if shuntable vein, or if it is patient is having non-shuntable or thrombosportomesenteric venous system, we can consider devascularization procedure can be considered. And if patient is having decompensated liver and if come out of this problem, maybe a transplant is one of the option which will be the end to give a next life for the patient.
So devascularization and shunt surgery are the two surgical options when we are not able to control the bleed and interventional radiologist is not available. That facility is not available everywhere. Nowadays, it is we are fortunate that we are having multiple interventional radiologists in city. So previously, that liberty was not there.
Another one thing in varicose bleeding, if it is a non-cirrhotic varicose bleeding, surgeon may come in early if it is a growth retardation
Yes,
or
sure,
children
right,
economically poor patient.
Yes, yes. When there is a NCPF or EHPO, then yes, surgical options are better than compared to the interventional radiology or even for the conservative management. When our conservative management will fail or when there is a hypersplenism which is symptomatic, in that case, shunt surgery is the better option. So there is a last case, that is 45-year-old male on dual antiplatelet presented with hematemesis, with marginal hypotension and tachycardia, non-alcoholic, history of intermittent abdominal pain, bloating, nausea and vomiting was there. So what is probable diagnosis? So us?
Patient, again middle-aged male with history of patient who is an antiplatelet with hematemesis, who is non-alcoholic, history of abdominal pain. Probably this is a non-varicose bleed, probably due to an ulcer in the stomach or in the duodenum. That's why the patient has bled. This is called as peptic ulcer bleed, and that is because of the antiplatelets what he is taking.
Yeah, this patient is on antiplatelet drug. He is about 40 years and he is having dyspeptic symptoms. So that possibility of ulcer bleed is there. So peptic ulcer bleed is responsible for 30 to 67% of the upper GI bleed, and mortality and morbidity is quite high, from 5 to 13%. Risk of morbidity, risk of mortality is depend upon the age, comorbidity, severity of bleed, and occurrence of recurrent bleed. In which patients you will suspect the gastric peptic ulcer bleed? Prasad?
So there are many risk factors for developing ulcers. If the patient is having chronic pain condition and he is having NSAIDs without prescription, most of the times it happens that we prescribe NSAIDs for 5 days and he is taking for months along. If the patient on antiplatelet agents like aspirin and clopidogrel, if he has chronic history of gastritis or GERD and H. pylori infection, if the patient is consuming steroids and alcohol and smoking are the common risk factors for developing ulcers and ulcer bleed.
So drugs like NSAID, antiplatelet, anticoagulant drugs, steroids, chemotherapeutic agent, phosphate supplements, alcohol and smoking are the risk factor for the ulcer bleed. A patient coming to you with upper GI bleed and dyspeptic symptoms with history of any of these drugs, possibility of peptic ulcer bleed is there, and we have to keep in mind. What is the medical management when patient is presenting first to you? So us?
So the basic management again remains the same. We have to resuscitate the patients. First and foremost, as the patient is on antiplatelet, role of PPI is very alarming in such patient. We have to start PPI during an emergency. The PPI is proton pump inhibitors in the form of any PPI which are equally efficacious. But IV PPI which are available are esomeprazole or pantoprazole can be started either as IV infusion or bolus doses. But what we start in our practice is we give a bolus of 80 mg. Start in emergency, start with 8 mg per hour infusion. That is for 48 to 72 hours till the patient stabilizes. Along with other methods like airway resuscitation and circulation care in the form of IV fluids and blood products.
So after resuscitation, we have to start the PPI. PPI will increase the gastric pH. Our target pH should be more than 7, and high pH will stabilize the clot, so further bleeding will be prevented. So 80 milligram bolus followed by infusion or BD, both doses are equally effective, so that we can use twice a day 40 milligram or we can use the 8 milligram per hour as infusion. What What are the endoscopic methods, Prasad, for the management of ulcer bleed?
So most commonly we find is D1 ulcer bleeding. There is all the acid in the stomach goes into duodenum, and the gastric wall is much thicker than the duodenal wall. So that acid, the duodenal wall gets exposed to acid, and the patient develop ulcer. So now why I mention this position, because it is very difficult to maintain the scope in the D1. So endotherapy options available are injection therapy, mechanical clips, and thermal therapies. So injection therapy, what we routinely use is diluted epinephrine. Now what happens when we see there is active bleeding and our camera is very close to the bleeder, we cannot see anything. So first step is to find out the vessel or root cause from where the patient is bleeding. So at that time we inject diluted epinephrine, which gives at least temporary tamponade effect, or it causes vasoconstriction and the bleeding stops. Then we can see the vessel and we can definitely treat the vessels. So options available are the thermal probes, that can be a hot snare which we can coagulate the vessel with the tip, or coag grasper forceps, or bipolar cautery appliances are available like gold probe. Gold probe has a benefit that we can inject with the same probe and apply it with the same probe. The contact methods which we are using has advantage that it can give mechanical pressure also and coagulate the vessel. The clips, endoscopic clips which are available, has advantages that they mechanically compress, and the results are as good as the surgical ligation of the vessel. But again with the clips, we have to maintain the position and keep the clip in the right way, apply the clip in the right way, and it requires practice. So what I do in my practice is to do the thermal therapy, which has a consistent and better effect and easier to apply.
So bipolar cauteries like gold probe, heater probe, and injections with fluorescent or epinephrine, over the scope clip or resolution clips are the clip options. Then argon plasma coagulation, these are the endotherapy options for the control ulcer bleed. So ulcers are classified as per the Forest classification, that is type 1 is arterial spurting, type 1B is arterial oozing, type 2A is visible vessels. First three these types will require active endoscopic treatment. For the 2B, that is adherent clot, we have to decide risk versus benefit, and type 2C whether there is a pigmented flat spot, and type 3 where there is a clear base. In these last two cases, we will not require endotherapy treatment. So ulcers with spurting, oozing, and ulcer with visible vessel, we have to treat with either of endotherapy. And in ulcers with clot, we have to decide as a cost benefit. Thin base ulcers with flat pigmented spot, there is no need of any endotherapy. So these are the few pictures. In first picture, there is a clip applied, that is a resolution clip, and bleeding is controlled. In second picture, there is a gold probe is applied. By the bipolar cautery coagulation, the ulcer bleed is controlled, and the left side lower picture, there is a injection therapy is used, and by injection therapy the bleeding is controlled. So Suhas, what is your opinion, whether monotherapy is sufficient or we have to combine two therapies?
So it depends on again the type of lesion, where when there's active spurting lesion or oozing is there, combining injection therapy with contact therapy or clip therapy, it is better than always than monotherapy like injection. When there is adherent clot, sometimes injection therapy alone sometimes can be useful, or only clips also can be useful. So depending on the type of the lesion, that is biotherapy or using two therapies together is better. That particularly in the patients who are actively using or having spurting lesions.
So in a high risk bleeding ulcers, that is having spurting or active oozing, in that cases dual therapy is always better than the single therapy, and in less risky ulcers we can use the single therapy. So what is the role of as an interventional radiologist to control the GI bleed?
Actually our role comes when the bleeding is not controlled by the endoscopic method. So they will try 2-3 times. If it's still leaking, then definitely we have to take consideration of the endovascular method. So I would suggest first, I think if patient is not hemodynamically stable, straightforward DSA is indicated, because DSA is not only diagnosing the lesion, but it is a therapeutic modality. So if you see any artery which is giving a hypertrophied feeder to the ulcer base, and most of the times our GI's consultant has the diagnosis on hand. It's a D1 ulcer, so we have to probe only gastroduodenal artery, we have to see the vascular flush, or you are probably can get pseudoaneurysm also. So if you find such kind of thing, we can just probably close the artery by coils or glue, or for that matter the PVA particles. Our role is just to give us some flow arrest, temporary flow arrest. So coil is a much more safer, coil embolization is safer, because once you put a coil in the parent artery, the flow in its branches will be gradually slow, and it allows the clot to form a stable clot there, and it will stop the bleeding. And same time with the coil embolization, the collateral circulation is preserved. So it do have some disadvantages also. In subsequent time, the collaterals will grow and there are a chance of the repeat. So, but it allows the time for resuscitation and the ulcer control also. So our role comes after the endoscopic failure.
Bleeding where we cannot access, that is in small bowel, there they are where they are very helpful to us, and where we cannot achieve any control by any of the endoscopy methods.
Another advantage of the clips is they can localize. Actually, even if my clip cannot stop bleeding, the intervention radiologist can localize the vessel which is bleeding, because he can see the clip under IR and selectively embolize the vessel.
There is a role of prophylactic embolization. Even if you don't see any vessel which is leaking, but since the gastroenterologist has applied the clip, under the X-ray we can spot out the clip, and nearby artery we can just prophylactically block with coils.
So what do you suggest, Vivek, with
So US guided coiling is used for variceal bleeding, not for ulcer bleeding.
So basically, US coiling is done by the gastroenterologist. Our coiling is endovascular from within the blood vessels. No, we don't.
No, US guided is endoscopic ultrasound guided. That is for the gastric variceal bleed.
So endoscopic ultrasound is another probe attached to the endoscope. We can actually see the varix by ultrasound method. We can see it in the endoscope, and by ultrasound we can puncture the varix, and through that needle we deliver the coil. That is US guided coiling. And for this coiling, they take a puncture in the femoral vein, and then they approach the artery and embolize it.
So Vivek, what you will advise? Suppose patient is hemodynamically unstable, you will advise for CT angio or directly DSA?
Unstable patient, I think DS is the best method, sir, because it
So
doesn't
both
require
are
palpation.
same sensitivity?
Yeah, in fact DSA has much more resolution. Even the smallest amount of the blood leak can be diagnosed, and DSA is a therapeutic thing, so you can go ahead with the
In the same
intervention in the same setting.
So what my experience is, our interventional radiologists ask for CT angio. It wastes some time. It is risky.
Yeah, so that I purposefully asked this question.
What they say is they already know where to go in and put some contrast. They cannot keep putting contrast everywhere. And
if you have localized the bleed, suppose you localize bleed in the duodenal ulcer, so we have to probe in the two arteries only. Celiac, either we have to see the gastroduodenal artery and otherwise the left or right gastric arteries.
when the patient is massively bleeding, is hemodynamically unstable, we are not doing scopy, and we ask for interventional radiologist to come in. So that time you need CT angio.
If you don't have a localized bleed, so probably the CT angio is a clue where we have to go. And second thing, it gives anatomical idea also.
Cases where even before we are approached, when the patient is massively bleeding, we ask them to do a CT angio with it, which is hardly a job of 5 minutes, which will give from where it is active bleeding, and when we can go either by doing gastroscopy or colonoscopy, which will decide if the patient is bleeding from below. Then it is better to do colonoscopy first rather than doing gastroscopy and then colonoscopy. So CT angio is hardly a 5-minute job, which can at least help us to guide where which procedure can be done urgently.
While doing CT, one most important concern, don't give any positive oral contrast. Because if the technician gives a positive oral contrast, our contrast exhaustion will be hindered and will not be able to localize the bleed.
So if patient is unstable, then it is better to go either with a CT angiography, then localize the lesion, and if interventional radiologist is available, directly go for the DSA, and if your lesion is localized. So Samrat, what is your role
As of
in the
now,
controlling
case has
ulcer
been
bleed?
discussed and localized the vessel where it is bleeding, what is happening. The role of surgeon, nothing is working. To save the patient, we need to open the abdomen. And if it is a most probably peptic ulcer, even bleeding is there at the base of ulcer, do the longitudinal duodenotomy and take a figure out stitch which can stop the bleeding. And prior it used to be added vagotomy. Nowadays availability of the PP and other thing, rather than wasting again time and again motility issue for the stomach. We can avoid the vagotomy just doing the figure 8 stitch, which will salvage the patient and take it out from the trouble that.
Thank you. Thank you. Any questions?
That was really excellent, sir. I think you are really tired.
ते कशाला उचललं
You need some juice or something, it is there, you can have.
अच्छा हां
Please come.
नाहीच उचलणार
Thank you all the panelists. May I request Dr. Raju Variani, sir, President, Dr. Kedar Patil, Honorary Secretary, and Dr. Virendra Ostwal, Joint Secretary, to come on to the dais to felicitate our panelists for today.
बसायचं मग ते चेअर्स चेअर्स म्हटलं मी ऐकलं चेअर्स आत्तापासूनच रेडी चाललं चाललं आलोच मी जाऊन चला यूज नको म्हणतील ना पेमेंट घ्यायला पेमेंट आता हे थोडी देणार अप्रिशिएशन करायची काय करतो बाबा रेडीच आहे एकदम रेडी तर काय करत आहे हळू पुढं वाजव पण हळू घेऊ का इथनंच त्याला म्हणू का फरक खायला दिसत नाही त्याच्यात त्याचा फ्लॅश असं कसं आहे त्याचा फ्लॅश असं कसं आहे वरती लावलंय रे त्याने फक्त मोराचं पीस कर रे एंड स्टॉप क्रिस्टिंग नाही ना झाले की वास की आता तर स्टॉप अरे कर मी काढणारच आहे असं पण फोटो काढायचा त्याला पण टेन्शन नाही आमचं
May I now request our Joint Secretary, Dr. Virendra Ostwal, to express the vote of thanks, and just wait for vote of thanks. Then outside, hot tea is waiting for you.
म्हटलं त्याला पण ते टेन्शन मध्ये आलं काय झालं
I thank on behalf of IMA Pune, I thank Next Gen GI Center for this wonderful GI conclave. It was very successful. I thank the convener, Dr. Maindad sir. I thank all the panelists, chairpersons, speakers, as well as all the delegates. I also thank the team of Next Gen GI Center as well as IMA who supported this conclave. Thank the photographer as well as caterers. Thank you all the delegates. The tea is being served.
नाही ना जे यात येईल तेवढं
थँक्यू
काय करू मग फोटो घेऊ का स्ट्रीमिंग करू
आता
स्ट्रीमिंग आहे चालूच आहे
ना 5 मिनिट
हां चाल
लगेच घेतो आपण
दादा माने साहेब कॅमेरा हलवता येणार नाही बरं
जेवढं होईल तेवढं घ्या
इथनंच काढेल येईल सगळ्यांचा फोटो चला बऱ्यापैकी